Good evening, everybody, and a warm welcome to Scope Parent Training Workshop Series. My name is Ashwini, and I am a parent support specialist at Scope at SKN Foundation. Before we dive in, here is a quick introduction to Scope. Scope stands for Special Needs Community Outreach Program for Empowerment, and our mission is to support South Asian families of children with disabilities through education, advocacy, and empowerment. If you want to know more about our work, please go to our website at myscope.info. Tonight, we are talking about the changes that come about in our neurodivergent kids when they hit puberty. We have our expert speaker, Dr. Bindu Khanna, walk us through the changes that happen in our children and how we can best support the kids at this stage. Meet our speaker, Dr. Bindu Khanna. She is a healthcare provider. Primarily, she graduated from medical school in 1991 and has 35 years of experience. Her specialty includes child and adolescent psychiatry. Dr. Khanna will share more about her practice when we get to the later parts. And before we dive in, here are a few reminders for our audience. Please know that our workshops are for general information only and are not intended to replace professional guidance. Thank you everybody for joining us, and thank you Dr. Khanna for taking the time to speak to our families. Warm welcome everybody.
Hi everyone. I'm Bindu Khanna. I am a board certified adult and child and adolescent psychiatrist. I am the director of the outpatient behavioral health services of St. Joseph's Hospital in Paterson, and I have my own private practice in Livingston. Am I still muted? Someone on the chat is saying I'm muted.
No, Dr. Khanna, we can hear you.
Okay.
Hear you, yeah.
Okay, I'm going to turn off the chat so I don't get distracted. So, couple of things. In addition to all my professional qualifications, and I am also the mother of an 26-year-old son with severe autism. He is nonverbal. So what I am talking about is usually what we have experienced in our family also. So it comes both from the medical knowledge as well as personal knowledge of handling a lot of these issues. I am extremely grateful for, people like the SKN Foundation, Dr. Mehrotra, and all the volunteers at Scope, because, it takes a village to raise a child. And when you have a special needs child, all the more so. It is much harder. And creating a community that supports you, that helps you through it, becomes crucial. I have depended many a time on communities like this to get me through difficult times. So thank you all for taking the time to do this, taking the time out of your day, and I hope that some of the information I present can be of help. Post the discussion, we are open for question and answers, and feel free to ask about anything. Also, I will be using appropriate medical terms through this discussion. So I hope it is not offensive to anyone, but I think it is, we've all been through a lot. We're probably going through a lot. So I hope we're all okay with that. Okay, so Archana, can I have the next slide, please? Okay, so I'm going to start with this discussion about normal puberty. The thing with our special needs children, while emotionally and cognitively and in terms of maturity, they are delayed. Physically, their bodies grow at the same rate as other neurotypical children. So usually puberty starts for girls anywhere from 8 to 13 years of age, boys a little later, usually a couple of years later, 9 to 14 years of age. This is a time when our body is basically mature. You know, so the physical process that happens is in your brain, you have the hypothalamus. The hypothalamus releases what is called the gonadotropin releasing hormone, which then goes to your pituitary gland, which releases the gonadotropin, gonads, tropin attracted to the gonads. That hormone then goes on. The pituitary gland releases what's called luteinizing hormone and follicle stimulating hormone. These in turn go and act peripherally on the ovaries and testes, depending on obviously the sex of the child. And that then proceed to release your sex hormones, which are your estrogen and testosterone, which then precipitate your pubertal changes. At this point, once this whole process starts, your physical changes start, but along with physical changes, there is also a lot of mental and emotional development that is happening, because simultaneously your entire body is in a significant process of development. Next slide, please. So what I'm going to go through briefly here are the developmental changes we see. Khanna stages is what your pediatrician will use to identify what stage of growth your child is in. I'm just going to go through it very briefly. This is very easily available for reference on Google, so don't feel compelled to go to pay a close attention. The reason I'm going through it is so you can start beginning to understand what you are going to see in your special needs child, and gives you a bit of an assessment of when changes start occurring. So stage 1, whether it is in the males or the females, is more the initial part of the process, which is happening in your hypothalamus and your pituitary and your internal organs. Physically, externally, you will not see any changes. Stage 2 for girls is when you start seeing the development of breast buds, and the breast buds start developing. That's a little bit of a mound, and the areola starts developing, the dark pigmentation around your breast buds. At this point, for girls, you might start seeing fine hair developing on the labia. What we mean by the labia are in their private parts, the lips covering their private organs are referred to as the labia. So oftentimes people may be looking for armpit hair, but that is what gives you the first indication that your child has hit puberty, and you can kind of expect them to start developing their periods a year and a half, 2 years after that. There is also the enlargement of the private, the clitoris, the uterus, and this is when your body odor also increases because of the other changes in other glands of your body. Next stage, same, the entire process continues. There is more visible increase in breast size, armpit hair starts increasing, pubic hair starts increasing. It's usually about, it starts developing like a triangular shape pubic hair. At these times also, the height increases of your child, visible increase in. By stage 3, you're going to start seeing acne develop because of hormonal changes. Emotionally, what you're going to see is a child becoming irritable when these processes are happening. So a lot of times when I have young girls coming in their preteens, in their prepubertal stages, this is the most that parents will start noticing. My child is becoming irritable because of all the hormonal changes. By stage 4, breasts develop, the nipples are more defined. It's now separate from the actual the breast mound. Pubic hair increases, height increases, acne can increase significantly. Your periods have started. Usually by this stage, if you see your child's breast development and pubic hair is pretty significant, but they do not have their periods within 3 years of this change, you need to bring it to the attention of your pediatrician. Stage 5 is final stage. Your body is considered the same developmentally as that of an adult. Pubic hair at this point may go down the thighs, or it may even, you may develop the central line in girls where it is going down from the belly button to the pubis. Usually by about age 16, most girls have matured. Next slide, please. Okay, these are Tanner stages for boys. Again, these are not hard and fast, but there will always be some fluctuation. Boys, similarly, first stage, you're not going to see anything. It's a lot of the internal changes that are happening. By the second stage, you will start seeing a sparse growth of hair around the penis. And then also arm hair starts growing with boys. The height starts increasing significantly. There is also a decrease in, what we call baby fat. And there's an increase in muscular tissue. They also start having a body odor. By the next stage, continued growth of both the penis, the testicles, sperm production increases, and wet dreams start happening. Wet dreams is when there is ejection, there is ejaculation and release of sperm, frequently at night, which is why the term wet dreams. And you will see darkening of pubic hair, increase in pubic hair, increase in height, a lot more sweating, increase in body odor, and the voice begins to start cracking. In this stage, you will also sometimes, for boys, there might be a development of a little bit of breast mass, which usually resolves. This is also important because if your child is already on medication that sometimes like risperidone that causes an increase in prolactin and can cause gynecomastia, it's a little, you have to pay attention to these changes and compare. Stage 4, adolescence in full stride. There is increase in penis size. The ridges start developing on the testicles. Body hair, pubic hair, everything increases, right? A lot of times people start thinking body hair and facial hair is the indication of onset of puberty. This is actually a fairly late stage of puberty. And then final stages is stage 5, where puberty ends, you are considered an adult male, is also when you start developing facial hair. Your beard, mustache. Again, prior to this, you may have some fuzz, but now you can have proper dark facial hair. Usually ends in males by age 17, but height can keep increasing till 20. Usually for girls, puberty lasts, once it starts, can last about 2 years. For boys, it tends to be more prolonged, can last about 4 years. And during which time the height also will continue to grow. Next, please. Okay, so a lot is happening with the body at this time, right? For all of us, we've all been through it, we know it. Very difficult time to understand your body, to see what is going on. In addition to all the physical changes which may not make sense to our children with special needs, there is also a lot of emotional changes, right? So what we find that children during this stage become extremely sensitive. They become irritable. They get anxious, things that they may not have reacted to previously, you will see them reacting. Depending on the functioning level of your child, there is also a lot of increase in aggression to sensory triggers that may not have caused this before. Because of how overwhelming the entire process is, you might see regression in your child's communication skills, right? Because they have trouble understanding a lot of what is going on and how to handle this. How to express it, how to handle it. becomes very challenging. Social skills, like their communication skills, get very difficult. This especially for the higher functioning special needs children. As it is, they struggle with their social emotional interactions. During puberty, what tends to happen is obviously their age-related peers are also going through the same stages. However, social emotional development jumps, exponentially during the stage of puberty. So even a lot of times when we have high functioning special needs children or children where they are also hard to diagnose, we're not sure. This is the stage when you start seeing the child with special needs fall behind in comparison to their siblings, to their peers, right? Because I always tell my medical students when I'm training, think of a child at their pre-pubertal stage. This is the stage where socially, they don't want their parents buying their clothes for them, right? You may get your deal at Children's Place or Amazon or online or wherever, and you buy bulk clothing. They're not interested. The neurotypical child wants to pick whatever is trendy. Even if they get fewer clothes, they'll pick what's trendy. They'll pick a hairstyle that's trendy. But your child with special needs does not feel the need to make those changes. So they tend to fall back even more compared to their age-related peers, because now their differences become more obvious. They are probably wearing clothing that is still more childlike than what their peers are wearing. And this becomes especially important when you have higher functioning special needs children, where you may have to step in and pay attention to those details and try and help them a little bit more in the choices that they are making, so that they can continue to fit in or be maintained in a higher level classroom or social setting that they are trying to fit into. Emotional and self-regulation, much worse during this time, but we will talk about it further. There's a lot of externalizing behaviors and aggression that happens during these times. Next slide, please. Archana? Okay. So I'm going to do a little bit more of free association talking during this time, because it, for the next couple of slides, because this is more based on what I see in my practice, where I am in Patterson by default, partly because of my own son, and recognizing that children with special needs do become challenging in clinic settings for providers. They take more time, they can be very disruptive. So, it's hard for most providers, even the ones who really want to help you, to bring them into their clinics. This has actually led to me seeing a lot more children with special needs and developmental disorders at my clinic in Patterson, because I realize there are very few providers willing to do this. So some of these difficulties is what I see a lot of. Older children. So let's go through some of the changes that we see. With older children, and not older children necessarily, but I mean higher functioning children, they may talk in a manner, they are concrete, they are very direct, they tend to be black and white, they may not appreciate social nuances, and therefore they will talk about these things in settings that become very uncomfortable for a parent. So frequently I have had children at these stages, they will walk in and I can see that they have an erection, or they, partial erection. And again, because their body size has not grown, it tends to be more obvious as opposed to when their physical body has increased in size. So any increase in genital size becomes more prominent, and frequently they are uncomfortable. So they are constantly touching their private parts or moving them around, not in an attempt to self-stimulate, but more in an attempt just to feel comfortable. And this becomes very embarrassing and difficult, both for the parents, because, the parents always concerned that the children are embarrassing themselves, or they may be misunderstood as not being good parents. And of course, when they're coming to a provider like me, it's fine. Sometimes I bring it up as a topic because the parents themselves may be uncomfortable talking about it. But in social settings, it can be a lot more difficult. With more impaired children who have a lower level of functioning, it becomes where they actually strip down. They have taken off their clothes because it feels so uncomfortable. They sit and they are actually exposing themselves, or sometimes touching their private parts and I don't mean over their clothes and trying to adjust, but literally constantly putting their hands down their trousers, their pants, to touch their private parts. It's also, remember, these are new bodily changes for them. They do not understand it. So frequently they will put their hands down their pants, take it out, smell it in public settings. And for the parents, all of these visually and socially can become embarrassing, but then it also becomes part of how, constantly reminding your child about appropriate social boundaries and how to take care of themselves. What I've frequently found also, it becomes difficult for siblings, it becomes difficult for other family members around the child, right? So as a parent, you are learning to manage your child, but if there is an older sibling, a younger sibling of a different, especially of a different gender, you want to protect your child of the opposite gender, also of the same gender that is younger, from this exposure. It is premature. They may not understand it. And here you're trying to teach one child, how to keep their clothes on, how to sit right, and then you have another child exposing themselves. So this becomes extremely difficult for parents to manage. Sometimes there's a lot of criticism faced by relatives, friends, who may also stop inviting you over because of fear of exposure of their children to your child's inappropriate behaviors. I have also found that for a lot of clients, based on their cultural beliefs, their value systems, they find a lot of these behaviors personally offensive. So I have had, where parents are embarrassed, one, for their children, but they also feel badly for their children because they feel their child's dignity is being compromised by their exposure in public. Also, their religious beliefs are being strongly compromised by the child who is doing this in front of maybe their opposite gender sibling, even sometimes the parents themselves, right? I have had, where a female child is exposing herself in front of the father, or the reverse, the male child is exposing in front of the mother. And it becomes very challenging for the parent themselves to step in and take care of the child because it's of the opposite gender. And before they can address the behaviors, they themselves have to come to terms with this behavior. Caretaker stress increases significantly. The aggression is usually because of release of hormones. Sometimes it can be because, there is already an increase in aggression, and when a caretaker is trying to limit the child from their actions, that alone can lead to a significant increase in aggression. Next slide, please. So some of the challenges that frequently come across, and again, this somewhere is at the level of functioning. So as I've said, at the lowest, at lower level of functioning, I've had children that will expose themselves, they will strip completely down to no clothing, or take their clothes off, both in school, in the home, outside of the home. Frequently masturbation that happens in front of others or in the living room. Sometimes there has also been where a child starts recognizing that these behaviors are causing getting them a lot of attention. And suddenly when they are beginning to take off their clothes, suddenly the entire family is on them, around them, and it almost becomes a game sometimes, not in a sexual manner, but more because for the child it's just amusing that they've got the whole family around them, and it almost they start playing with the family. And I've seen kids sitting there giggling, laughing, stripping while the parent or the sibling is trying to dress them back in the office. The masturbation too, I have had children where they'll, family get-togethers, they're sitting on a sofa and they suddenly masturbate, not realizing how socially inappropriate this is, just because all the family members around are becoming offended by it. Or sometimes they just want to be left alone, and they know that if they do this, they are left alone. In school or somewhere, mid-level of functioning, even when parents have been able to talk to their children about not exposing, and they are not doing that, they, however, because of their the changes in their emotional and sexual development, they start becoming attracted to others. And this could be either persons of the same sex, persons of the opposite sex, whatever their inclination might be. And they may do this by being obsessed, by touching hair, touching body parts, arms, shoulders, sometimes keeping on requesting the person to give them hugs. This can sometimes even happen within family members, because they may find it soothing to feel a family member's body parts. So this can create a lot of problems in school, especially if your special needs child is not necessarily in a placement, or more of a LLD placement, or a gen ed placement with pull-out resources. The other thing that I do find happening is a lot of obsessing over a person. So for kids that are older or may have access to phones, or they are higher functioning, they're in high school, constant texting or talking or following people that they are obsessed with, and this definitely needs to start getting addressed directly. Next slide, please. So we're going to talk about how do we manage a lot of these behaviors. Again, this is more general. You will have to change this based on what, adapt this to your child's needs, right? So we start, solving any problem is by communication, right? How to communicate also becomes difficult based on your child's developmental level. But as much as possible, even if it is uncomfortable for you, you will have to talk about this, especially if you have a verbal child or a child that understands, understands what is happening. The more direct you are about this, the better it is. Don't use words that are confusing or childlike. It is, it is better to use words that, use the correct terminology, use correct body terminology, however uncomfortable, penis, vagina, body parts, identifying body parts, breasts, buttocks, things that teaching them what is personal, what is private, what areas they are allowed to have contact with, right? You will have to also, while it may be against your religious belief system, against your value system, you need to understand when a child has, so for male children, when they have erections, this is not necessarily because they are aroused. It is part of puberty. It is going to happen. They are not able to control it. It's just part of the physical developmental process, and not being offended by it, understanding what it is. Because sometimes I have had parents where, they see their child with an erection while the child is playing with their siblings or their cousins, and they find it offensive. And, please understand, this is not something your child is able to control. Some of the things that I tell parents to do is, especially with males, use tighter underwear, maybe even boxer shorts, because it allows for a little bit more coverage. Maybe if your child allows it, try to use boxer shorts and then, cotton shorts over that, just to increase bulk around their private parts, and use long t-shirts to cover their private parts. You can get into the more stylish short ones later. Again, understand, once the process of puberty is over, and as the child gets older, the spontaneous erections do become less. So it's a matter of 3-4 years, usually the first 1-2 years, where it is extremely problematic, and then later on it does subside. If you have a child, again, erections are natural. Exploring the body is natural for anyone within the animal kingdom, which includes all of us human beings. We are considered part of the animal kingdom. So even if it is offensive to you from a religious standpoint or from your own value-based system standpoint, you might just have to let your child explore their body. A lot of times, males will masturbate when they feel the pressure to release. Eventually, they will end up ejaculating. In my experience, most even cognitively impaired special needs children find a way to do this that's comfortable to them, whether they do it by rubbing against a pillow, rubbing against, a cloth, or against their comforters, or just rubbing against their beds. They figure out their own way, and let them. But just try to, when this activity, if you see it, if your child is severely cognitively limited and you see this activity happening, let's say in the living room or in a more public area of the home, then maybe redirect your child to go to their bedroom or the bathroom and shut the door. So somewhere your child begins to understand that this is something private, and they and give them the space to do it. Please do not hit or spank them in response to this behavior. They are not able to control it, right? And that will only trigger more aggression. I always tell parents, when you hit your child when they are upset, you're teaching your child that it's okay to hit when they are upset. So please, do not do that. You will have to constantly remind children, like you have to with your neurotypical teenagers, about boundaries of behavior, about boundaries of communication. if they want to talk about this, they want to talk about how the pubic hair is bothering them, or it's itching them, or it's feeling uncomfortable. They may bring this up in the middle of a school get together or a school, and you are going to have to remind them these conversations are important. I do want to talk to you, but let us talk about it when we are home and when we are alone together. These are private conversations that we need to have privately, right? This, again, extremely stressful time for families, and seek the support where you need it. Scope, great place, but sometimes I've even advised parents to seek guidance from their religious leaders, because it can be very upsetting to a lot of families when they see their children going through these changes. Frequently, we find that for children that are on medication, we need to adjust their medication doses during this time. Sometimes children that have never been on medication will need to be started on medication around this time because of the behavioral changes. Next slide, please. Okay, so this is, again, just a checklist on things that can be done. So what you do for your child, depending on their functioning level, you can either do a written checklist. If you have a child that is severely limited, do laminated images of what you need them to do. Create a schedule when they need to wash themselves. And this, I mean, not just during the time of periods, but even daily hygiene. Hygiene needs to, they will have body odor. So reminding them of taking a bath, during a bath, to wash their private parts, to wash their armpits, to wash below their breasts. So all the areas that are likely to become, more malodorous if they don't take care of it. Teach them how to do that. Teach them to brush their teeth, to comb their hair, to use deodorant. This sounds simple, but they have to be reminded constantly, right? So if you can create a checklist and give them visual reminders, please do that. For most of you that have neurotypical children, that even with your neurotypical children, they don't do this. So imagine your special needs child. So giving them this list becomes important. For females, especially create a self-care kit. Obviously, in the beginning, you're going to have to teach them how to use a pad, when to use a pad. You may also have to give them, remember, with special needs children, there is leaving it to them to decide their judgment of when to change a pad doesn't work. So maybe it's just easier if you give them a guideline, right? We're going to change it in the morning. We're going to change it again as soon as you come home from school, and we will change again before you go to bed, right? So it becomes routine for them, depending on your child's the periods. If they have heavy periods, you may have to send a kit to school also, so they can change in the middle of the day. I know sometimes it is difficult for parents, and also create separate kits for the school and for home, so the child does not get confused and is not running out of items that they need, right? Sending an extra set of clothes to school also might be important, so the child is not embarrassed when they are doing it. Using a spray deodorant instead of roll-on should be considered. I have sometimes found, and this unfortunately more so with South Asian parents than with other communities, even though their child is physically growing, the tendency to want to wash their child themselves, completely understand special needs children do not do a great job of cleaning themselves post defecation, even during periods. So teaching them to use things that will allow them to do this independently, right? So a scrubbing brush or a loofah, or using a bath seat in the shower so they can sit and clean themselves properly, teaching them to use a removable shower head that they can then use in the direction of their private parts or their bottoms is important. I have frequently found that parents will continue to clean their children's bottoms, or wash their bottoms and wash their private parts even as they grow. The challenge with this, one, you are not fostering independence. Two, when they are in other places, they may expect other people to do this. And unfortunately, children with special needs become victims of sexual abuse at least 10 to 20% times more than neurotypical children. So when you keep doing this and they expect others to do it, whether they are in school or in day programs or the home health aide that comes to your house, you are also increasing the potential for your child to be abused. The other risk of doing this, because I have seen parents when they do this, then when they do the NJ-CAT, they will say, my child doesn't toilet independently. This restricts the kind of day programs that your child can go into if you say your child doesn't toilet independently, only because they will not clean themselves properly, right? If your child you can sit independently on a toilet and for both urination and defecation, it is considered independent toileting. Their hygiene is not going to be perfect, but don't say that your child doesn't toilet independently, because then a lot of programs, one cannot take them, or they will put your child with even lower functioning persons who need help with toileting. I have also had parents who will allow their child to wear diapers all the time just as a coping strategy, because especially with the girls who get confused with periods, when to change period pads, and it has just become a coping strategy of letting them wear adult diapers, and then once they start staining or the periods start, then obviously changing more frequently than they would otherwise, right? Honestly, I think necessity is the mother of invention, and frequently I find that parents come up with better solutions to problems than any of us professionals can. And okay, next slide. With this, I'm mostly done. These are just resources for you to learn about talking to your child about puberty, body changes. You can even Google this. All of this is available, these resources. So use it to teach your child about their body. I should have, but I did not check if there are any books. But I mean, I'm presuming most of you, if you are logging in from the States, your child attends an English-speaking program. I did not check if there are programs that are bilingual that will help you to translate or teach your child. Sorry about that. I mean, again, I'm giving this opinion based on what you're telling me without evaluating your son. But personally, in my experience, when they start becoming aggressive at this age, it is actually better to start medication, even if you start with low doses of medication, because they are physically big. A 19-year-old, autistic male is extremely strong. When they are in the aggressive state, the strength increases. It is very hard to control. It also causes a lot of trauma to the family. I mean, you understand this is your child, but at the same time, when you have unpredictable aggression, even for family members, it's the constant, walking on eggshells, not knowing what's going to trigger your child. It's dealing then with your own anxiety, because a lot of times I see parents who end up having almost like a PTSD response to their child. So the minute their child's voice gets raised, or their the body language changes, the parents start becoming anxious, right? I try to look at it this way: when a child is becoming aggressive, they are not in a happy state of mind. And if your child had a headache, or if he was having an asthma attack in front of you, you would certainly try to relieve that condition. Similarly, if your child is becoming aggressive, they are overwhelmed, emotionally overwhelmed. There is literally a burst of neurochemicals inside their brain, which are struggling to, settle down, to stabilize. I would actually suggest use of medication. You can do medication along with therapy. And as your child gets older, suppose this is only related to puberty. As your child gets older and becomes calmer, once you start it doesn't mean you have to continue it for a lifetime. You can always taper down. Do this again with the guidance of a physician. Also, at this age, if your child is 19, they're going to be graduating out of the school system by 21. When school starts seeing aggression, that gets recorded in your child's evaluations. When they get to be 21 and you're looking at day programs look very closely at all these behaviors. And then it makes it difficult to get your child into a day program also. So trying to get a handle on this and get your child's behavior under control fast, for everyone's sake, but more than anything for your child's sake, because he's not comfortable right now. Even with medications, I'm sorry, but I'm going to say that sometimes, depending on each person, right? Sometimes parents are able to predict ahead of time, right? So they can see, your child best. They can see body language changes, or certain circumstances in which they know the potential for aggression is more. In that case, you can try using what we call as needed medications, PRN medication. So you don't have to give it all the time, but you can give it when you see those changes. But at the beginning of seeing those changes, don't wait till your child is already in an aggressive state. When you start noticing early signs is when you give it, because the medicine does take 1 to 2 hours to kick in, then you give it. Some parents don't have a warning, or they don't see those triggers signs. It's just complete unpredictable aggression, in which case then you have to consider medicating, low dose medication, but all the time. There's always an ideal scenario. So it is, know what you what you want, but you take what you get. Maybe even put the pad in the period underwear. Start with panty liners and then just move up slowly. So your other question about the compulsive behaviors. Compulsions is a part of autism itself, right? Ritualistic behaviors, compulsive behaviors are just part of it, right? Most of us have seen it a million times, right? We hear the same music that my son plays like 2,000 times a day. Challenge is when the compulsive behaviors becomes a matter of safety, it becomes injurious to others, then you do have to treat it. When you do it for people who are verbal, or children that are verbal, we can try habit reversal. There are certain techniques that can be used. However, if your child is cognitively limited, let's be honest, it's very hard to trust this. CBT is an excellent form of therapy, but you need to be able to understand and OCD is treated with medication. Mild to moderate cases of OCD in neurotypical people who are fully aware of their symptoms can be managed by therapy. And it is moderate to severe cases of OCD, neurotypical, or OCD in, even in autistic children where it's becoming problematic. And we do use medications. The one thing I will tell you about OCD symptoms, when someone may be having a seizure disorder, you're trying to treat them where they are not going to have any seizures. OCD symptoms are difficult to treat. We are not looking for 100% resolution. Then that is what we do with treatment for OCD. Yeah. OCD also is a fluctuating illness, right? So there will be periods of times when it increases. There will be periods of times when. So even when we are treating, we expect fluctuation. We expect changes. We are not expecting 100% resolution. Even reduction can make a big difference. So even giving you an example, I have one of my clients, severely autistic, nonverbal, and when she was going through her periods, part of what happened was she would start rubbing herself against any surface, even on the school bus. She was literally rubbing it. It felt better. It felt good to her, but very low functioning. The challenge became that she was doing it so much that it was becoming obvious. And then our concern became at that point, whereas in other circumstances, she probably will not allow anyone to get near her because she was aggressive. If someone actually touched her private parts, she might even let them. It would give her relief from whatever discomfort she was feeling. And so we actually used medication for her. And frequently in these kinds of situations, we have used medication more sometimes to reduce even the obsessiveness that they experience. So, some of this resistance is natural, right? It is not, all children resist suggestions by their parents. Children with ADHD even more so, right? I keep telling parents with ADHD, right? Even with neurotypical teens, preteens, you will be repeating till you're blue in the face. With children with ADHD, even more so. It gets very frustrating, but the process is longer because puberty and the cognitive development is slower. Unfortunately, you're going to do it longer than you would have to otherwise, till it becomes an internalized process. Maybe consider also whether giving her a reward system, right? Okay. Not necessarily punishing, but when she does a good job, rewarding. So, kids are more likely to do something for a reward than as a punishment. What tends to happen with higher functioning special needs children, you're looking at your child, she looks like a 13-year-old, her body is of a 13-year-old, and somewhere, you want your child to be cognitively functioning like a 13-year-old. But the reality is it's likely that cognitively your child is still an 8-9-year-old. And you need to teach her or keep reminding yourself that this is not a 13-year-old mind in a 13-year-old body. This is a much younger mind in an older body. So how you would teach an 8-9-year-old child is how you will teach your 13-year-old. Try a reward system. Certain things are not a lot of the hygiene and things are not going to be up to standard. It's okay as long as they do it, right? Make her do it more frequently if that's, but and this is where I find a lot of parents get stuck because they're like, oh, they're not washing their hair properly or they're not washing their armpits properly. Like, that's why the parents go in to do this stuff, right? And I'm like, it's okay. As long as they are doing it and they get used to the idea that someone's not going to be in the shower coming in and finishing the job for them, right? It's sometimes, there's the saying, right? Perfection is the enemy of good enough. You're going to have to settle for good enough for some things. This was part of what one of the earlier slides was talking about, the emotional sensitivity that they develop. We see it in all even in neurotypical children, the emotional sensitivity, and it increases significantly with autistic children because there's just so many changes going on in their body and their environment. Some of the things that you will have to consider: limiting the social gatherings or limiting the time you spend in the social gatherings, or considering like give her a way of communicating to you when she's feeling overwhelmed and what your plan will be if she is getting there, right, before it happens. So if it's like, okay, I need a break, or I'm getting upset, then it can be, okay, what do you want to do? Would you like to go sit in a room? And you said this is also with family and friends who know her, right? So again, you're doing everything right. So by preparing her, by talking to her, by not forcing her to interact more than what her comfort level is. So all of that is wonderful, and continue doing that. You may have to consider alternatives, like if you're going there, limit the time, or if these are people known to you, ask if they can give you a place where your daughter can sit by herself. So not just in a corner of the room where everyone is, but maybe just literally a separate space where she can go sit down and calm herself down. Sometimes parents even take a break in the car, right? Like rather than leave the event, but always be prepared for this. With special needs children, autistic children, getting overwhelmed can happen very quickly. Be prepared to take them out, separate them, give them time to calm down, and then rejoin the gathering. Sometimes they might, sometimes they may not, but give them the option.
But thank you so much for such an amazing presentation, for sharing so much knowledge, your expertise, your personal experience with your patient, and your translation, right, of how we as South Asian parents see many of this is very uncomfortable to talk about, and you made it such great points, and thank you so much for all of this amazing information.
You're welcome. Thank you for having me. And thank you for all the amazing work that Scope does.